Looks like we're all in. Warm welcome and good afternoon on this cold Johannesburg Wednesday afternoon. I'm going to be starting with a little bit of intros, but before I do that, John is just going to take us through little small legal formalities that we have to in terms of POPI. John, over to you.
Thanks. Good afternoon, everybody. So in line with the new POPI Act, we just need consent to the utilization of your names on our social media platforms. So assuming, of course, that you consent to your personal info being displayed online, please just advise us should you no longer wish to be identified, and if so, then we'll ask you to please remove your name and or any formal identification, and of course remove yourself from our platform. And we don't want you to do that. So by staying online, we assume that you consent. Thanks, Evie. Back to you.
Thanks, John. So for record-keeping purposes, we are recording the session. The session will be available for viewing on our YouTube channel. And with that, formal introductions. My name is EVY MICHALOPOULOS. I am the founder and the CEO of the Mahifilotimo Cancer Project. John, co-founder and director of the project and also our legal advisor. Thank you, John, and thanks for joining us again.
Thanks.
And today we're talking about a very interesting and topic that's always very close to our heart in terms of our new section and leg in the project, Filotimo Kids Club. We're focusing on creating as much awareness around children's cancers, childhood cancers and palliative care for children. And we are very blessed and proud and privileged to be able to have our guest speakers join us today all the way from Cape Town. So today we are joined by PatchSA with Sue and Tracy, who are going to give us their little introductions as to who they are, where they're from, amazing individuals, and the work that they do in Cape Town and all over is something that's brought much smiles to our own faces and hearts, because it is a sensitive topic. But enough about me and our side. Can I hand you over then to Sue? Sue, if you wouldn't mind, just a little intro and welcome explanation. And we're going to do a presentation. Please, if you have any questions, you can put them down in the chat box. Alternatively, as Sue ends off her introduction, we will have a Q&A. Alternatively, Tracy will then commence with her presentation, and then we can do another Q&A after that as well. So over to you, Sue. Thank you so much.
Sue, you're on mute.
Hold on. There we go. Now we can hear you.
Now we can start. Thanks so much. And we're really very grateful to have this opportunity to introduce you to the work of Patch and to talk to you about the really important role of palliative care in caring for children with cancer. Can I share my screen?
Yes, please.
And let me put it on there. Can everybody see my screen?
Yeah, that's perfect.
Great. Okay, so Patch South Africa. Who are we and what do we do? So, I don't know, why is this not? Does anyone know how to get it to move? Oh, there you go. Okay. So we are a non-profit with PBO status. We're presently led by a steering committee of 9 people from all around the country. We are in the process, we're chaired by Dr. Michelle Mayring from Petersburg in Cape Town and vice chaired by Joan Marston, who I see is on the call. Hi, Joan. And we are in the process of becoming a non-profit company, and at which time we will transition to having a board of trustees. We have a staff of just 2. So that happens to be Tracy and I at the moment. And we both work from our homes, which actually isn't in Cape Town, although our official address is in Cape Town. Tracy lives on a beautiful farm near Matatiele. And I live in Assegai, which is at the foot of the Valley of 1,000 Hills in KZN. So a little bit about Tracy and I. Tracy is a professional nurse, and my background is actually in education. I'm a teacher, a writer, but I've been working in children's palliative care since 2008, and Tracy, I think even longer than that. So we do have number of years of experience in children's palliative care. A little bit about PATCH. It has 3 streams, or 3 audiences, as we like to say. There's the community, so our advocacy to the community. We want people within the community to understand what children's palliative care is and to support those families who need palliative care for children. Then we have an arm that reaches out to the parents and those who are directly affected by illnesses and conditions that need palliative care. So we provide support for the families. And then our third is in a stream for healthcare professionals. So those members of the multidisciplinary team that Tracy will no doubt talk about, that will provide palliative care to children. So we support them through resources, through networking, through information sharing, and through our latest project, which is through education. I'll tell you a bit more about that. Our strap line, I think, sums it up beautifully, is people who care, supporting people who care. So PatchSA, we are that hand that is holding the hand of the family member and the child. So we are supporting the people providing care to children. A little bit about our history. In 2008, the idea was floated to set up a national network of children's palliative care, people working in children's palliative care, as well as some organizations and some hospices who were providing children's palliative care. Joan, who's, as I mentioned earlier, our vice chair, was very much instrumental in this because she worked for HPCA and in fact started one of the very first children's hospices in South Africa. In 2012, the South African Children's Palliative Care Network was launched, and that being rather a mouthful, in 2013, we came up with the acronym PatchSA. And it was presented, the new name was presented at the HPCA and APCA conference in Johannesburg. So HPCA is the Hospice Palliative Care Association, and APCA is the African Palliative Care Association. And those are just a couple of photos from those meetings, the original committee down in the bottom right. You'll see me at the very end, and Joan is the third on the left. This is a little bit about how we look at the moment. This photo was taken in 2018 at the International Children's Palliative Care Network Conference, which was held in Durban. At the time, I was working for ICPCN and Joan had been the CEO of ICPCN. So let's just have a look. So that is the staff of Patch, Tracy and myself, our chair and our vice chair, Joan and Dr. Michelle Mayring. Our youth ambassador is a young girl from Cape Town who actually has a condition that requires very close pain management and palliative care. Then these people are previous or present steering committee members. And there at the very end is a very special person who is Sister Frances Dominica. And she, in fact, started the very first children's hospice in the world in the UK, which is called Helen House. And she was a special guest at the conference. And just to show that it's not all doom and gloom, and we're not all very serious, talking about very serious things. This is a group of steering committee members and training committee members from PatchSA, all wearing a hat or hats on for children's palliative care, which I'll talk a bit about later. 5 of those people are doctors, so we all do have a fun side to us as well. What is our aim? It's very simple, and it says to ensure the right of every child to access quality palliative care in South Africa. Sadly, there's We estimate there to be close to 1 million children in South Africa with a life-limiting or life-threatening illness. And in a study carried out by ICPC and UNICEF in 2013, showed that less than 5% of those children had access to palliative care, which is extremely sad. Our mission then is to mobilize and support a sustainable network of individuals, organizations, professionals, and caregivers to provide palliative care to children and their families, from diagnosis to bereavement, something that Tracy will talk about, as an essential component of universal health care. So palliative care has been recognized as an essential component of universal health care. It's not just an add-on, a nice to have, it's an essential component. So I'm just going to be looking at some of our objectives, as you will see on our website, and how we meet those objectives. So one of them is to create and sustain a vibrant network of individuals and organizations who are interested in children's palliative care. And we do this by having membership. So anybody from the community, anybody who is a parent or caregiver, and anybody from the healthcare network can join our organization. So there is a charge for healthcare professionals and community members. Parents and family members of children with a life-limiting illness can actually join for free. So that's how we build up our membership, and we create our network through a membership, through a network of members. This objective is to promote the development of support systems for children, families, and professionals and lay caregivers. And we do this through, we have any member that joins us actually is invited to belong to our medical support group, which is a WhatsApp group. And we have a number of doctors and nurses and social workers who belong to this group. And it's a wonderful way of passing on information, giving advice, helping each other, networking. We also have our social media platforms, including one that we have started for parents and families of who have lost a child, who are bereaved. It's called Patch People Who Care. This objective is to be a repository of information on children's palliative care, resources and service providers in South Africa, and to promote local appropriate guidelines and standards for children's palliative care. So we do this a lot through our website. I do invite anybody who's on this call and hasn't had a look at our website, please go take a look. We have numerous resources that are freely available for you to download from our website. And we are also, Tracy and I, at just the end of an email or of a phone call. We also do this through the publication, or we have done this through the publication of a book, which was launched in 2020, and it's called Palliative Care for Children. It's a Better Care book. Better Care is an organization that is been trusted for many years within South Africa, particularly within the hospitals. They have published numerous books on different topics in healthcare, and ours was published in 2020, and it gives a really good South African perspective of how to provide to children, and very easy to use as well, how to provide palliative care to children. This objective is to promote access to evidence-based education in children's palliative care for professionals and for parents. And with funding from the Discovery Fund, we were able last year to start the Patch Academy. It was one of the very few positives that have come out of COVID, because previously the plan was to do this as face-to-face training, and when that became impossible because of COVID, we went back to the drawing board and we decided, let's find a way to still provide training and we came up with the Patch Academy. And I really, really would encourage you to go and have a look at the Patch Academy. We've got numerous courses. I'll tell you, these are the courses that we have. Every one of our courses has CPD points from the CMSA, and so that's for doctors. And we also have, some of our courses have been accredited with CPD points from the pastoral, spiritual and pastoral council, and also for social workers. We've just had one of our courses accredited with CPD points for social workers. So please do go and have a look at our courses. They give a really, really interactive education and experience on what children's palliative care is all about. And we have one for free. So if you just want a little bit of knowledge about what children's palliative care is, please go and do our free course. We also provide face-to-face training, and we look forward to doing that again one of these days, hopefully in the near future, in the not too distant future. Okay, and then advocacy. One of our objectives is to be a strong collaborative voice for the right of the child to receive quality palliative care in South Africa. This photo was actually taken in 2019 at a high-level national stakeholders meeting, which was held in March 2019. And coming out of this meeting, and it was with members of the Department of Health and the Patch Declaration of Children's Right to Palliative Care came out of this meeting. It can be signed. You will find that online as well. And then one of our advocacy activities and our fun ones is called Hats On for Children's Palliative Care. And this was started by ICPC back in 2014. And it was just a fun way to raise awareness of the work of people in children's palliative care. We also wanted people to realize that palliative care is not just about death and dying. Palliative care is about quality of life, about bringing joy into the lives of children and families. And this day has grown and grown over the years. These photos were all from South Africa and taken last year. We have businesses, we have hospices, we have hospitals, we have schools that all participate. And it's a very, very simple way to participate. All we ask you to do on the 8th of October, it's the second Friday in October, wear a hat, take a photo of yourself, your friends, your colleagues at work, post it on social media using our hashtag HatsOnForCPC and tagging Patch, and then donate to Patch or any children's palliative care program that is near to you. And so that's all I have to say. I hope that I've given you a good enough overview of what Patch is and what Patch does, but please just reach out. I'm just an email or a phone call away.
Thank you, Sue. That was very informative and gives us a very wide range of services and the amazing work that you as PatchSA do. And I think it's also given us a lot of information as to how we can help grow more awareness and also open up eyes of the partners that are in our project as to how we can assist and help contribute in some way or another. Hey, John.
Thank you, Sue. Very, very informative and a nice introduction to what it is that you guys do. Has anybody got any questions at this point for Sue? If not, and of course you're welcome to put a little note in the chat box below. If not, if we could get on to our next guest, Tracy, if you wouldn't mind, perhaps you will answer some of the questions that I have for you guys in your little intro, if you don't mind.
Okay, you can see me.
Yes.
Hi there, everybody. I'm Tracy Rollins, and as we say, I came from a farm in Cedarville, Matatiele area, which is the Eastern Cape. And sorry, let me just share my screen. Sorry.
No problem.
I just want to start my slideshow. There we go. Anyway, I'm a palliative care nurse and educator by profession, and it's been such a privilege to be part of PATCH and to be able to take our training and education forward. And it's been very exciting developing our PATCH Academy, and we're just hoping that through initiatives as partnering and being asked to do presentations to whatever organizations are out there willing to let us share our knowledge, our enthusiasm, and the expertise that we've got. So I would just like to say thank you for this opportunity that you've presented to us, and that we can be part of your initiative as well. So today I'm going to be speaking on the role of palliative care in caring for children with cancer. My presentation might be a little bit long, so I might skip some of the points in this, but we'll cover what we can for now. And if there are any questions that pop in with the slide, please feel free to just stop me and ask. I don't mind, put it in the chat box, and we can carry on as we like.
So Tracy, I'm going to hit you with a question already, if you don't mind, so that we don't lag behind.
Okay.
A question from one of our listeners: how do you assess the quality of life of children receiving palliative care? Tough one.
Okay, so that's such a big, broad question. Actually, how do we assess the quality of a life? So through the presentation, maybe this question will be answered, because there's so many different aspects to what we can say quality of life is. Great. And how do we improve that quality of life? So really, that's what, and you've jumped the gun, but the aim of palliative care and one of our biggest goals is to improve quality of life for any child living with a life-limiting or life-threatening condition. So hopefully through the presentation that question will be answered. So how I thought of looking at the role of palliative care was looking at going through a journey, because we know that once a child is diagnosed with cancer, it's not a sort of quick fix until we go to surgery and you're cured in a couple of days. This is a long, bumpy journey, and is often a race against time with cancer. So we might be looking at a couple of weeks from diagnosis, depending on the stage of the cancer, or it could be a couple of months, even going into years, that this is a journey that this child and their family are going to take. So looking at the cancer illness trajectory, which is the course and pattern that the illness is expected or likely to take. And if we look at this diagram, we can see, I don't know if you can see it, we talk about we all healthy, and this is our time frame that we stay healthy. With the diagnosis of cancer, usually the child starts deteriorating once that, or that's what makes them go to the doctor, seek advice, is because the child is not ill. So then their health status would decline. So we'd get to a stage where where the diagnosis is made, and then it's this treatment might commence depending on what stage the cancer's being diagnosed at. And then we would see that it's a bumpy ride. It's up and down. With the treatment comes side effects. There's psychosocial problems. There might be spiritual problems. So there's not a smooth pathway that these children and their families are going to follow. Then after that period of treatment, which could take from weeks to months, they might then go into remission. Sorry, let me just go back into remission. And that could be for years, and if not for a lifetime. But we know that each child's journey is unique, and there's no one size fits all approach to how a disease trajectory might look. And then what we might see, there might be a period of remission, and then if there might be a relapse a few months later, a year later. And again, we might start with further treatment for that relapse, for metastases. And sorry, I just want to minimize this because I can't see my slide. And then might have treatment But that treatment might just not be enough, and eventually there is no more treatment that can be provided, and then there would be a decline and death. So we're looking at this journey, we can see it's not an easy journey, and it's a bumpy, rocky road that these children and families are on. So I thought I'd just look at some sobering cancer facts and stats around cancer, and I found these off the CHOC website, and also went to the cancer website where there were some of these statistics. And it's found that 1 in 600 children in South Africa is affected by cancer before the age of 16. So that's quite a high number. And funnily and sadly enough, that more than 40% of these children will never reach a specialist treatment center, either because the diagnosis has been made too late, or just because of logistics, where they live, how that care can be offered. And then it will be because of financial implications, available resources that they don't maybe have access to. And then again, if we look at the survival rate for childhood cancer is only 50% in South Africa compared to 80%. And it links back to that available resources and treatment centers that can actually, these children can be sent to where they can stay and get the treatment they need. Then some of the other facts that we look at, that many of these children who do die from their cancer often have high intensity treatment towards the end of life. Even though the cure may not be possible, they still may be experiencing treatments that have severe side effects that really don't enhance their quality of life, and can almost add sort of a poor quality of life because of the intensity of these treatments. And then half of the children who do die in acute settings, and we're talking about emergency rooms, hospitals, where they suddenly deteriorate and then they have to be admitted. And that's not the place where the family and maybe the child want to die. They often want to be at home in their safe environments with the people that love them, care for them, support them. And I mean, if we think of this time of COVID, and there's been quite a few studies out recently on the impact COVID has had on families whose children have got cancer, and how it has impacted on their support services. And then one of the biggest concerns for us, and globally and locally, nationally, is that often referral to palliative care services occurs late in the illness trajectory. And if you think back to that diagram of the illness trajectory, often it's when that relapse has happened and there is a decline and the treatment is not working anymore. Then that's when the team say, well, maybe we should consider palliative care. And when we look at why palliative care is not always included in this cancer journey that the children experience, is because of the myths that surround palliative care. One of them is that we only need to implement palliative care when there's nothing more we can do. And I think those are the dreaded words that any parent faces who've got a child with cancer, is there's nothing more we can do. And in palliative care, just one of the things we try and advocate for is that there's always something we can do. And we'll talk about that a little bit later. And then once we implement palliative care, introduce it, means that we've given up hope. Now there's no more hope for any possible quality of life, any possible future. And then the third one, palliative care is only needed at the end of life. And hopefully through this presentation now, we can dispel some of these myths and understand why it is so important to include palliative care along this bumpy, rocky road journey. Okay, so the question begs to be asked, where and how does palliative care fit into this cancer journey? And what is its role in caring for children with cancer? The WHO definition of children's palliative care is quite long and in-depth, but I think it's worth having a look at. So it starts with that palliative care for children is the active, total care of the child's body, mind, and spirit. So it's a holistic approach that is active. It's not sitting in the background, just hands off and not being involved, but being there if we need it. It involves giving support to the family, and that is so important. A child is part of a family, and it might be an immediate family, it might be an extended family, and community is also part of that family. So it's important, it's giving support to everybody involved in that child's life. And this is the pertinent point and fact, is that it should begin when illness is diagnosed. And it should continue regardless of whether or not the child receives treatment directed at the disease. And then health providers, so it's not just one health provider, need to evaluate and then alleviate a child's physical, psychosocial, or psychological and social distress. So again, the only way we can do that is by assessing that specific child and family's need. Then effective palliative care requires a broad multidisciplinary approach that includes the family and makes use of all available community resources. And it can be successfully implemented even if resources are limited. And I think that's also a point. We can always make a plan, even if there aren't available resources. And that's where PatchSA and our networking organizations really have a big role to play. And then it can be provided in tertiary care facilities. So those would be your bigger hospitals where they are within oncology units. It can be offered in community health centers by those that have had some palliative care experience and knowledge. And it can even be offered in children's homes. And I think that's one of the biggest goals is for any family is to be able to care for their children at home as much as possible and keep them out of hospital as much as possible. So I'm going to just show you this little video clip, which sums up the definition. And just please let me know if the sound is playing. Okay, so it's a beautiful video clip of just what palliative care and what it encompasses. So when we talk about cancer and making decisions, we often have to decide what path do we take on this journey. And we look at oncology care, which is the first step of the way. And then we talk about maybe considering palliative care. So let's look at what the focus of oncology care is. First and foremost, it's disease focused. It's there to treat the cancer and possibly cure the cancer. It includes identifying the type of cancer, and then the treatment is then geared towards that specific type of cancer. And it could be either chemotherapy, surgery, or radiotherapy. And most times this chemotherapy or radiotherapy is provided in tertiary hospitals or in oncology units by an oncology team. And then the focus of palliative care, which you will see, is quite different. And what the focus foremost is about is that it's patient and family centered. It's about communicating with that family, being available to that family, finding out what is important to them. How do they understand the journey of cancer? What are their expectations? What are their needs? And again, it's about improving that quality of life. It doesn't necessarily just have to be the clinical picture or the illness itself. It's about giving that child purpose and meaning for while they're alive. So if it means being able to run outside, that is improving quality of life. And often it's not always about the quantity, the time length they've got, but it's about how they live that time that they have got. Another focus is that big focus is preventing and treating symptoms of both the disease and then the side effects of treatment. And when the severe side effects, the palliative care team have used the specialist approach of the doctors who understand treating these side effects with medications and pharmacological managements. And then also another focus is decision making. Often it comes to decision, where are we going to treat? How are we going to treat? What type of treatment are we going to be? That will be the oncology, but the decision making is with the family is, what are you looking for in the future? What decisions will we need to make? And we talk about parallel planning in the inevitability that the treatment is not successful. And then we talk about putting plans in place. So we'd look at drawing up a care plan that included all aspects of their child's life, whether it be psychosocial, spiritual, physical, and then come up with goals of care and let that be implemented for the child going forward. And then if the child towards the end of the life, if the cancer isn't cured, then we'd look at doing and implementing an advanced care plan, putting something in place in case of an emergency, in case of deterioration and decline. What are the goals going to be then? Again, palliative care can be provided in any setting. So it can be provided by the staff in a hospital, it can be provided by clinics and communities in their settings, and it can be provided by the parents in the home as the primary caregivers. And again, one of the big functions with palliative care is that it's a team approach. And we talk about meeting the needs of the child where they're at that moment in time. So if the child is having chemotherapy, intense treatment, that would include the palliative care doctors, the nurses, the social workers in that actual setting. Could be another time when the child is home and they're looking at education or play, and then we would involve other therapists and professionals that can meet those needs. So it's meeting that child and their family where their need is. So as you can pick up, that multidisciplinary team can be very diverse. And then again, this team complements the cancer care team's work to ensure their patients. So it's working hand in hand and supporting each other. It's not one team or the other team. It's walking that journey as teams collaborating together. And then another focus would be is planning and providing end-of-life care if that was a necessity. And then it doesn't stop there. Palliative care works into the bereavement period. So if that child does die, there will be care and support for that family after that. There'll be support groups, there'll be connectedness from the palliative care team supporting that family for a period after time. So you can see that there's a big focus of palliative care and how it can complement oncology care. So when we look, the best approach includes both a curative and a palliative care approach. Palliative care, in essence, helps through the ups and downs of the cancer journey. So then how does palliative care help with the ups and downs of the journey? And this is the aspects that we would look at. And you saw in the video and here, we want to prepare for the worst and at the same time hope for the best. What is the prognosis going to be? What is the outcome? And we want to be prepared for any inevitability that happens. And so when we go on a journey, we think of packing, and if we're going on a long road trip, especially if it's going to be a bumpy off-road trip, we need to pack everything in. We need big suitcases. We have to have thought of every aspect that would be needed on that journey, whether it be food, provisions. And in this case, we're even going to look at packing that umbrella that's needed to help with shelter. So it's like bringing out that umbrella to shelter all the needs of the child and family. And when we look back to that definition of palliative care, we saw that it was care of the child's body, mind, and spirit. And it's an active approach. And with that, we look at all these different aspects and needs that this child and family may have. And we work with them as different components with different team members. So there's the physical aspects, the psychological aspects, social, spiritual, and cultural aspects. So it's using a team approach, and part of that team is the child and the family. They need to be the core. They are the center of their team. They are the ones that guide the decision making and ask for the help and the needs that they need for that. And then it's up to the palliative care team to help meet those needs. So how do we do that? So let's look at each of these components as separate entities for now and just see how palliative care can assist. So we look at the physical care, and that's the body. So when we would looking at pain assessment, what type of pain is this child experiencing? There are very numerous numbers of different pains that children can experience. And so we need to assess these pains. So to improve quality of life, again, I'm going to keep going back to the quality of life. We want to treat each of these different types of pain, whether it be a bone pain, a nerve pain, just a tissue pain. We need to know what type of pain a child is experiencing. And then we can only manage that type of pain if we know manage that pain correctly, if we know what type of pain it is. And often we think about cancer pain, but what else happens to a child when they're going through all their treatments? They have numerous tests done on them. They have bone biopsies, they have drips put up, they might need to be catheterized. You know, there's just so many, and we call those procedure pains that happen. And often those pains don't get treated accordingly. So we'd look at assessing and managing those pains as well. Then we do know with cancer, the symptoms can be vast and severe. And if a child's on chemotherapy or having radium treatment, There's even the added side effects from their treatment. And some of the biggest ones are nausea, vomiting, fatigue, and loss of appetite. And those we need to treat symptomatically as they occur. And that's where that care planning comes in, where we would be anticipating what might happen and have something in place, a plan in place to treat those symptoms, and be educating the family of what they can do to help with that. Then a big role in the clinical management of pain and symptoms is the non-pharmacological management, meaning without medicines, but helping treat. So we think of things like distraction, and one of the techniques we might use with a child who's having a procedure pain, who might be having a drip put up or blood taken, is to give them bubbles to blow, to distract them from that procedure. We think of aromatherapy, we think of visualization. There's just so many non-pharmacological management techniques that we use. So it's not always about using just medication and treatment. And then part of that would be to plan for and provide end-of-life care. So if the child is physically deteriorating, we would look at what the expectations would be and the symptoms and pain that the child would experience at end of life. So the team that would be looking after the physical care would be doctors, nurses, and a therapist. And there's just so many different therapists that we can consider: physiotherapists, occupational therapists, speech therapists, to name just a few. Then the second part is that mind, the psychological care, and this is where palliative care looks at that aspect. And as much as we experience physical pain, children can experience emotional pain. And a lot of their pain that they experience is around fear, anxiety. Then there's feelings of anger, guilt, depression, sadness, stigma, and body image. And if we go back to this, sorry, I'm going the wrong way, slide here. If we think of just body image and hair loss, and the child's appearance with their peers, it's so important to them. So those are sort of something that they might have fears about, have concerns about. So we need to be having an assessment of all these psychological, social, and emotional aspects that will affect the well-being of the child. And very important in children's palliative care is that we need to assess and communicate at a child's level of understanding and cognitive development. We cannot treat children in the same way, speak to them. It's our language values, our body language. How are we communicating? And that's one of the expertises with palliative care. We understand the developmental stages of children and then assess and treat and communicate according to that. One of the other areas that we spoke about truth telling earlier, and is talking to children about the illness and death and not pretending it's not happening. It's about being candid, about being open, but again, waiting for that child to indicate their discussion. And we know children they will get straight to the point. And one of the questions will be, am I going to die? Which is just, that does play on them. And again, it's learning the skill of communicating correctly to have these discussions, building a relationship with them so you can answer that question. And I mean, one of the ways we say is to then understand, well, what do you understand about death? Do you think you're dying? And that's where we would take that question from there. So we get back to where they are in their understanding, and we don't surmise that we need to go into great detail. And then one of the big factors is from the time anybody or any child with the cognitive understanding of an illness is anticipatory grief. So we will talk about grief, but anticipatory grief is understanding the future losses that are going to occur. So for parents especially, it's all of those future events that they anticipated: their child growing up, their child going to school, their child writing a matric exam, going to a dance, playing sport. And for children themselves then, the losses of not being able to be with their peers, not play in sport, that's all loss, and that's considered anticipatory grief. And we have to work with that with children. So you can see the team that would be needed. It would be a big team. And again, it would be, where is this child and family? Who are their needs and what are their needs? And then that's where our social workers, psychologists, nurses, counselor, different therapists, and we talk about art therapy, music therapy, and one that I haven't mentioned here and who should be on this list is our teachers. Are we talking to the teachers if the child is school going, involving them, involving their schoolmates? Sorry, am I running out of time? I'm nearly done. Then looking at the social care, and that again also involves the mind. But what we do in palliative care is we do family assessments. We look at the family as a whole, the family dynamics, how that family functions, what is their culture, what are their traditions, and then we assess, because the only way we can improve the quality of life for any child and family going through this journey is to understand that family and who they are. And as Sue said earlier, children have a right to palliative care. Children also have a right to play and education. That is how they learn. That is how they grow. That is their work. So we need to be considering all those aspects of their social development. Often the forgotten people are the siblings, and who's supporting these siblings through this? Are they being communicated? Are they involved? And then again, we look at the community. Who is that community supporting this family? Another role that we look at and providing is legacy planning and memory making. So we start that early, and it's an important part and function of a child's development. They want to know that they're important. They also might want to know that they will be remembered. And legacy planning is something that we can do with older children. And memory making can be done with any child, right from small, doing handprints, drawings, making memory boxes. So there's so much we can do in that aspect to improve their quality of life. And again, that team involved here would be your social worker, nurses, your play therapists, aromatherapists, your art therapists, your music therapists, then counselors, and then support groups that we would refer families to get the support. So it would be cancer groups, child groups, grief and loss and bereavement groups if it came to that. And then of course involving the community. And then the last aspect and area that's very important to consider too is providing spiritual care. That is part and parcel of who we are. Every child and family wants to know that there's been a purpose to life. They want to know what gives life meaning. What is the purpose of life? And then it's important that we understand the difference between religious and spiritual care. There is a difference. And it's about doing assessments to understand what is important to that family. And that's how we would provide spiritual support. And then again, we have to look at culture and traditions. How do these families practice their spirituality and their religious activities? And we need to involve those. And again, it would, to give meaning and purpose in life, that would include the legacy making and memory making. And then part of spiritual care would also be bereavement support when that child dies, and walking that journey with that family. And again, the team here would be your spiritual workers, your chaplains, your sometimes, I mean, we've got to consider in palliative care is traditional healers as well. So we include whoever that family need into the care and planning with that family. So when we look at this in summary, and we look at these two pictures, we say that palliative care helps take the cancer journey from this, and you can see the kept out calm, the little boy who doesn't look too comfortable, to this: comfort, safety, and security. And that is how palliative care can help improve quality of life and help walk that journey, cancer journey, with the family. And then Michelle Mayring, just to finish off, she said, if they're cured, it's fantastic. If not, the patient and their family already know what palliative care is about. So the transition to the end of life care is seamless. And that is the importance of introducing palliative care early on, if not from diagnosis, in this path journey, cancer journey that the child and the family take. Any questions, thoughts, ideas, comments?
Can I just ask you a question, Tracy? With the palliative care control policy, I'm not sure if it's been passed yet, the adult one, but does the children's, will that fall under the adult palliative care policy? Do you know?
Yes, it was part of that policy. Sue, do you want to answer? I know Sue also was quite involved with it.
Yeah, children are included. It's across the whole age spectrum. So from neonates all the way through to adults.
Okay, and then your the state, and so I mean, do you cover state and private patients? I mean, if a family can't afford or hasn't got money to pay, then how do you cover it through your organization, like you said earlier, with other funding, or how do you?
Okay, so Patch itself doesn't provide, our work is more supportive and strategic. Okay. Palliative care for children is provided by a handful of children's palliative care programs within South Africa. Joan started Sunflower House in Bloemfontein, which is still going strong. There's PatchSA in Cape Town, there's Oncology in KZN. Northern KZN has Butterfly Palliative Home. There's Northwood Children's Hospice in East London. No, just Gqeberha, sorry, Port Elizabeth. And there's Lambano in Johannesburg. And that's kind of about it. A lot of adult palliative care programs do look after children, and all hospices and all palliative care programs provide care for free. There's no cost involved. So all these handful of children's palliative care programs all rely on public funding and fundraising in order to continue their work, which is a hard task, let me tell you. It's not easy. So they're constantly having to look for funding in order to provide the services. Joan will tell you what a strain it is just to get through each month. Yeah. So we're hoping in time, when the government does come around to funding palliative care, that children's palliative care will also benefit at some stage. But yeah, we're not holding our breath.
Any other questions that we can ask Tracy and Sue? There's one in the chat box there. Let's have a look quickly if we can answer that, or someone can just.
I think that was a comment from Joan. I have a quick question for you, if you don't mind. And we are running out of time, but what an excellent presentation. And I think we could go on for hours with you guys. It's just so many parts to this machine.
True.
And we're inviting you back, guys, so please come back again. And
we love to be back.
My question is, what if the child doesn't indicate or initiate the discussion and keeps quiet about it? How as a parent or as a caregiver, how do you approach it, and do we approach it?
Again, it's sorry, I'll answer. There's no direct answer for that, because initially it's about building a relationship with that child and the family first. It's building that trust, and it's going with where they're at. So it's being able to sort of watch their body language, their play activities. What are they doing in that? And often it's just by being next to them, not actually even talking to them. They might just be sitting with you and they're playing, and you can ask a question, and they might start talking about their feelings, what they think their journey is, so there's no way to approach a specific way. It's not like we're going to decide today's the day we're going to sit down and have this discussion, and it's a process too of answering one question after the next question and then spending time with that child. And to be very honest, I mean, I was looking after a young 12-year-old boy a couple of years ago. Well, yeah, it's just over a year or so ago. And he was not convinced that he was not going to get better. And even to the end of his life, he did not want to really acknowledge or talk about it. He was convinced. And again, it was not our place to tell him otherwise, but we prepared the family and him in other ways. We improved his quality of life by getting him back involved in his school, allowing him to write his exams, the teachers would come and visit him, and that was the way that, even though he didn't want to acknowledge that he was dying, he probably did, so he still had quality of life towards the end. So it's a very difficult question to say. There's no right and wrong way of approaching that question. And again, I think it also goes to where your experts come in, your social workers, your counselors. Again, it's using them if you've got them available, because they have that expertise on how to work with the children.
Perfect, thank you.
Any other questions?
And I think it's what's important with palliative care is also to try and prevent that protective, that often you get the parents are trying to protect the child and the child is trying to protect the parents. So neither of them are talking, and it's to try and break down that wall and to encourage the parents to talk to the children, because they are the ones that know the child.
And often I've heard them say that often the children actually will say to the parent, will actually tell the parent that they are dying and that they mustn't be sad. I mean, I've read that quite a lot too. Often, the kids actually, so many of them actually do know that they are.
Joan will attest to that,
They're far more advanced children who are sick, especially with life-threatening illness, really have such a knowledge about their own illnesses and diseases and how they're feeling. They're more experienced sometimes than we are in their conditions. So they want to know everything, and they're open to learning, and they're quite frank too.
That's for sure.
Sorry, we just lost the connection there, but we're putting them back on. So Tracy and Sue, thank you so much. I mean, from our side, my understanding now of exactly what it is that you can assist with has completely changed as to how I saw palliative care for children with cancer. And I think for sure, 100%, and I'm actually so excited to hear about such positivity that comes with it, because I think, as you mentioned earlier, it's almost a subject, especially when it comes to children, that you want to approach with the parents, but the minute you say it's a palliative care program, facility, however you want to, place or term it, there's that always, we're not there yet. And from seeing what you can actually do, and as you've mentioned, you would like to be introduced at the diagnosis. So whether the diagnosis is still very early or whether the diagnosis is very late, your role in terms of how you are able to facilitate, help and support this child and its family is so important. And I think that's what we're going to create a lot of awareness about. And also perhaps refer a couple of families that we are sort of assisting with, because your services and your support and education is not only termed at the late staging. It's helping the families understand the process of the treatment and what the child's going to feel as the symptoms, as you mentioned in your presentation, the nausea, the vomiting, the pains, the body pains, the scans, the taps that they do, all of the blood tests, all of that. So, and just being able to give the family that information at that point in time so that they can understand that process a little bit better is for us quite a big eye-opener in terms of what you do. So thank you very much for that. And I will be sending you some details on that if you could perhaps assist our fellow family members that are going through that, because what you do is really, really awesome. Awesome. Before we end off, any last questions? No? I think that's it.
We're done.
I think you've given us so much info. We're definitely going to have a second part and second session, because I think there's so much that we can talk about and how we can help grow assistance. But once again, huge thank you. We are going to upload the video onto our YouTube channel. I will also share your details, Sue and Tracy, if that's okay with all our members on our group as well. If they have any questions, they can contact you directly. Other than that, our session next week is going to be focusing on mental. Sorry, Trace, you want to say something?
I just wanted to say, I think what we would like to do is also, if just make aware of all the NGOs and hospices that actually provide children's palliative care, because that's who your families are going to be needing, is that resource. And it's actually on our website as well. So if you can maybe guide them to that if they're looking.
Okay.
Sorry.
That's perfect. Thank you. And I'll also include your website address for more information. Again, on the topic, we're focusing next week on mental health for cancer survivors. Our guest speaker will be our partner, Michelle Goldner, who is a master NPL life cancer mind-body coach. So join us again next week, Wednesday at 3. But other than that, a huge, warm greetings, and I don't know what the weather would be like, but we wish everybody warmth, strength. Please stay safe. It has been a little crazy the last couple of days with COVID and everything else going on. But once again, from our side, huge thank you to PatchSA, our partners in palliative care for children. Thank you so much for sharing so much information with us. John, you're ending off.
Yeah, just a big thank you to all of you for joining us. And I see we've got Larry from India. Larry, hi. We're looking forward to hearing about you and the amazing work that you guys are doing over there. We'd like to invite you on as a guest. So if you're keen to do that, please DM Evie or send her an email, and we'd love to have you guys on board and see what the rest of the world are doing. Big thank you to BMW, BRYANSTON, our partners who supported us and brought this to you. A very good afternoon to you all, and we hope to see you again soon. Cheers, everybody.
Thank you very much for
Thank you.
having us.
Bye.